Very good morning to all. Thanks, Dr. Raju, for inviting me. Okay, we'll come straight to this talk on PEACOCK's crown feather technique for a parrot beak tear. This is meant for a meniscus flap tear.
That's a very interesting title. Two birds superimposed on each other, eh?
So you know what's a parrot beak tear. It's an oblique flap tear. As you can see, that's what is a parrot beak tear for beginners. So as you can see, this MRI, it's difficult to go through all the images. It's a 25-year-old male who had a twisting injury a month back while coming down steps. ACL is intact and reported as a complex lateral meniscus tear. For your benefit, that's the zoomed up image. There you can see the lateral meniscus. You can see a small tear. Probably it's, as you can see it in the sagittal cut, it's a radial tear in the lateral meniscus anterior and middle third junction. And it was not picked up in the coronal cuts. And in the axial cuts, you can see the tear pattern where it seems to be a radial tear. So that's the arthroscopic video. As you can see, that's a small radial tear in the middle and anterior third junction of the lateral meniscus. So, to our first ARS question.
ARS, please.
So, how do you prefer to repair this type of meniscus tear? Inside out, outside in, all inside, or would you say, I would just exercise and balance? Okay, that's interesting.
The majority is none, and I would probably be in the majority as well.
Majority, yeah, okay. So I'm not going on with this case, so I'll leave this case. So I'll come back at the end of this talk. So case number 2. So here you can see another parrot beak tear. I guess what you would say for this case. It's extending till the red zone. It's going all the way till the red zone. It's going as a longitudinal tear. I'm not asking the ARS again, don't worry. I don't want you to answer no. So this is what was done for this case. I prefer repairing this. So this is what I call it as parrot beak pattern of repair, where it's a single suture passage with all the sutures going through a single hole in the flap and in radial fashions 4 other sutures. How did we achieve this? This is the final image. So how did we achieve this? This is what I try to call it as the peacock crown feather technique. So that's an Indian national bird for. So how did we achieve this? For this you need a open-eyed needle, free needle, where the thread goes through the open-eyed needle, and the two free ends, the double-loaded needle sutures are the 2 free ends. So the first suture goes through in the flap, and the subsequent 2 sutures go this way. This is just for a pair of sutures. So do the same thing, add 2 pairs, you get 4 threads. So in a single bite, you can pass 4 threads through the flap, and the remaining 4 threads are there where you can place it radially. So this is the external video image where you can see the 2 pairs of needles are away, and the first thread going into the flap, where you can see it in the arthroscopic image. This is the lateral meniscus anterior middle third junction repair. It's in the figure of 4 position. As you pass the needle, you would see the needle coming out. I don't place the release incision when we are anterior to the popliteus hiatus. So it's safer when you're remaining in front of the fibula head. And to be more careful, I try to use the anterior zone specific cannula, which is more curved, so that your needle doesn't come behind. It's anterior to the, as you can see, the needle coming out in front of the midline on the lateral side. In the second image, subsequently, each needle is passed in various configuration depending on which area you want the reduction first. Let's see the arthroscopic.
What is the position of the knee here, Santosh? I mean, it's not fully figure of 4, but then it's a modified figure of 4, is it?
It is almost figure of 4. I mean, the knee, the foot is in the opposite knee.
Okay.
It is in the figure of 4.
So you use a leg holder?
No, this is a supine.
On the table?
On the table, but for the ease of comfort, you can place a bolster or rolled sheet below the same hip. So
have you used the side support?
Side support is there, but if the side support is there blocking it, you should move it away in this situation. Okay. Bolster or a pillow below the hip helps in restricting the external rotation of the hip, so that you tend to get more opening.
Oh, that's a good tip. I'll probably try that next time.
and you need to keep moving the angle of flexion depending on which angle gives you better vision. So for this parrot beak tear, this is the peacock crown feather which we've advocated. I'll show you another case example. I found few challenges coming across by using this technique. This is a little chronic tear. Again, it is going on to the red zone. If you exercise, it's almost like a complete radial tear. You're going to lose the hoop stress. And you can see a grade 4 cartilage effect, which is small. So in this case, we are more in line to protect the cartilage by repairing the meniscus, which is exactly over the grade 4 defect. Even though I did a microfracture, you need to protect the defect area. So we decided to repair this one also. It's the same technique which I showed, where the first suture takes all the 4 threads in the flap. Trying to pass multiple sutures in the small flap might compromise the flap, and there might be rip-off. So by doing this, that's a couple of sutures already passed in the radial fashion. The third and fourth radial distance, more you stay away, you get a better control of your flap. So you can pull all the threads sequentially and manipulate your, there might be tangling, not to worry about tangling. You can pull it out in the first suture and remove the tangle. I'll show that again in another video subsequently. So here it is going, you must control your tension, and when you tighten the first sutures, the reduction is better. In this situation, the longitudinal tear was much longer, so I've added an all inside, and it is further posterior where it's risky to take an inside out. So over there, all inside is added to give a better stability. So I've added another suture on the inferior surface. We can see a flap over there. That helps us to reduce the
Santosh,
fragment.
can you pause? Billy has a question.
Santosh, I'm a bit concerned about, and the repair technique is good, but I'm more concerned about the biology there. So we have not done anything to the flap, which is all rounded. You just put the sutures across. I mean, I would have a lower threshold to kind of do a kind of a meniscectomy of the edge, and then do this.
Yeah,
I probably add some fibrin clot or whatever to it.
True.
To me, that would stay as long as the threads stay.
Yeah, true. Initially, my initial techniques were with the excision of part of it and a repair of the red zone. But as I've been doing more, I have good results. So in the next case, you would see me freshening the edges. In this case, if you try to use the shaver, you would lose that fragment and you cannot approximate. So that's the fear. Adding a fibrin clot, I was doing a microfracture just there. So just above that, so I was not worried about adding any clots over there because you're giving a bone marrow access right over there. That's a good point actually.
Yeah, Santosh, good technique. You are putting it on a superior surface, so does the meniscus gets lifted off while you are tightening it, and what is your sequence like? From posterior you tighten the...
Superior, and most of the time it is directed inferiorly, so the threads go in downwards. And the sequence depends on the pattern. I usually try to approximate the free edge first so that you get good reduction, then put the other radial ones. So that's the sequence usually I follow.
So you said that earlier on you would resect what was non-palatable to you,
Yep.
and you would repair what you found palatable, right?
Correct.
And then you moved on to repairing pretty much everything, even coming out central into the white.
So we've learned that radial tears do heal. White zone radial tears do heal well. So with that experience, radial tears, white zones, I'm not saying just a white zone, white zone which extends onto red and red does heal well.
So as you changed from this thinking to that, did you have your own MRIs post-op, or you had your own second look arthroscopies of your own patients? What made you change?
We had few MRIs to compare those posterior radial tears, but these cases I didn't have MRI because I tried doing MRI, it was hardly able to pick up those tears and those lesions. So second look scopy, no, it's just the clinical outcome. Majority of them, 80% were with an associated ACL. Very few of them were isolated lateral meniscus. Lateral is about 70%. Medial, you do have parrot beak, but lateral, anterior and middle third is the majority which I've done, which has given good clinical outcomes, 2 to 5 years follow-up.
So you might as well want to follow them up at some point and see what percentage of healing you are getting in which zone.
So would love to do a repeat arthroscopy, but it's difficult in our practice.
Adding to the same question, any difference you find out in the clinical outcome? Like previously you were doing meniscectomy along with the repair for the post-red zone, and now you are doing a...
No, yeah, good question. In the short term, 3 to 5 years, no, not much of difference. They don't complain in 5 years' time. So, no.
So like, because for such kind of clean cut repair, one has to be very much trained, because otherwise they would have harm more rather than helping the patient.
Yeah, when it comes close to this red area, I would say it is better to repair, but not to the first case which I showed. May not be the ideal case to try that. You might be overconfident to do that. But for a case where there is extending to the red zone, you would end up excising the meniscus. So 30-40%.
If you excise the white zone, and then when you go behind, you find out there is an opening in the horizontal manner, and if you repair that one, that will also help.
That's a degenerative complex tear. These are acute tears. When you see it along with in such situation where there's a neighboring cartilage defect, we want to protect the joint.
Nagaraj?
I would be able to answer when it's in the long term. In 10 years, I don't know. So that's a
So Santosh, first of all, very interesting technique. We should always look for newer ideas. So appreciate that. Now, if you actually dissect this tear which is extending, it is primarily a radial tear. So my question to you is, if you have a pure radial tear, let's not get into terminologies of parrot beak and radial tears. If you have a pure radial tear, we've been doing the hashtag repairs for quite some time now, because we know biomechanically the strength of...
Shall we ask after this ARS? That's about that.
Okay. And to also address the undersurface, we are just looking on top. All these radial tears are going through and through. So we always have to remember the undersurface of
the last case, I added a couple of undersurface sutures also.
Okay.
So the same question, we'll go on with this ARS, then come back.
Have you considered putting the pivot of this crown on the capsular side? Like, see, you're putting in those 3 needle ka insertion point on the meniscal side. If you reverse the crown, then the capsular side is more stable, and then those 3-4
So you mean the outside in rather than inside out?
No, you go inside out only, but instead of putting the center of the crown on the meniscal side.
So I've not tried it for the crown, but for the radial tear, when we have this X configurations, V configurations, then yes, but not for this kind of a tear.
You wanted to show more cases, Santosh? Can you please?
That's coming back to the same
Achha, the first
case.
one. Okay.
So that's the same case which we saw, which is actually mainly a radial tear, not exactly a parrot beak, and probably a small parrot beak just on the undersurface. Because I've been doing this, we went on to do a repair, which is a peacock crown feather. We have subsequently sutures placed. There was tangling in this situation. When there is
So you
tangling,
modified your radial repair with the multiple...
Correct. Exactly.
Okay.
So when there is tangling, pull the threads on the first suture, the tangling goes away. So that's a tip to get away from tangling. And that's the final suture. Even with this configuration, your radial tear can be repaired, is the point which I wanted to say. So the ARS, second question.
The second ARS, please.
So now comes, if for this kind of a tear, how many would prefer the hashtag or rebar, crisscross pattern, oblique sutures with partial excision of the white zone, or the peacock crown feather, or still say excise? Still 14% want to excise the entire thing. Hashtag, yeah, it's the mainstay, or the rebar, which is biomechanically stronger than most of the others. I would agree with this. As I've been doing this, I try to do this. But
Santosh, Subra has a point.
Santosh, I think your technique is excellent. A lot of them are partial red-white zone tears. Okay, normally we would have done a resection, or some of them would be a side-to-side repair. But because your configuration of stitches is so good, it goes into 3 or 4 pendants. It gives biomechanically strong. I think because it's biomechanically very rigid, it's going to union. And it may be happening, partial union is happening, but we have not done any arthroscopic look, isn't it?
No.
We have done MRIs for these post-op MRIs?
One case, but I couldn't pick up the tear.
But clinically they are good, isn't it?
They are good.
Yeah. So I think what is happening is partial union of the periphery, and because of the biomechanical strength, the remaining bit is also staying there. And eventually some fibrous tissue might be forming. That's what I think the conclusion it looks like.
Point well taken, Santosh. For want of time, we would end the talk